All right, so having completed our cycle and having actually started to characterize it in terms of what's happening in the hormones, let's do this, let's go through this in a fairly systematic manner, okay? First of all, these are the phases of the menstrual cycle. So this is the early to mid follicular phase, pre-ovulation. This is late follicular phase, leading to ovulation. This is early to mid luteal phase, and this is late luteal phase here. So we're going to go through this at 4 different phases, starting with A and ending at D, okay? Notice that this is a cartoon, which is why I'm not going to emphasize these changes in levels too much. And it represents the menstrual cycle, similar to the previous graph that I showed you with the real data. And we're going to bring that graph back as we go through these phases, okay? So let's start with our early to mid follicular phase, okay? That is this phase here, okay, leading up to the late follicular phase and ovulation, okay? We have our estrogen, which increases. It's being secreted from our developing cohort follicles, and of course, as you know, estrogen is causing those follicles to develop and feeding back and causing an increase in the number of granulosa cells during this period. So the estrogen is reasonably stable because the FSH is being kept under control, okay? So you see our FSH here. It is less sensitive to estradiol inhibition than LH, which is really low during this phase. And it actually does increase a little bit, but then it decreases, and you can see it's kept under control. And because it's kept under control, and because inhibin is playing a role in suppressing the FSH as well, and particularly at these phases, you have a reasonably stable level of estrogen here, maybe gradually increasing just a little bit, despite the fact that your granulosa cells are proliferating and your potential to make estrogen is getting greater, okay? The decreasing FSH here causes the atresia of the follicles, except for the dominant one, which has the largest number of FSH receptors. It is the one that can continue to develop the best at the lowest level of FSH, okay? And that, so we get our selection process toward the end of this phase and early in the late follicular phase, okay? During this phase, we have inhibin playing a role and causing negative feedback here, keeping FSH under control. And notice we have this negative feedback of estrogen upon the release of gonadotropins from the anterior pituitary, okay? So here we have our anterior pituitary secreting our FSH and LH are gonadotropins, and those are stimulating the follicle to produce estrogen. Here, the estrogen has this positive feedback loop on and causes the production of more granulosa cells and the development of this follicle. And at the same time, recruitment is going on. And notice again, we have this negative feedback keeping the FSH and the LH under control during this phase, okay? So that leads us to the late follicular and ovulation phase, okay? So here it is, sort of focused in on. And basically during this phase, the estrogen increases, and if it's up high enough for long enough, you will switch the feedback upon the release of LH to a positive feedback, okay? So here we have our granulosa cells. They're producing a lot of estrogen, that is causing this feedback to switch from negative to positive here, and that increases your secretion of gonadotropins and results in your LH surge. So here we have your high estrogen. Again, it's sensitizing the anterior pituitary to GnRH. It's priming the system It is stimulating the hypothalamus to increase the release of GnRH. We talked about that earlier. That results in the high release of LH, and you get this LH surge here. You also get this FSH surge. It is probably mostly due to activin rather than the positive feedback mechanism associated with estradiol. Okay, but you do get this increase in FSH as well. That leads us to the early to mid luteal phase. So we have the development of our corpus luteum. So after the fall in estrogen, after the LH surge is over and the FSH surge is over, the follicular cells increase the secretion of progesterone, and these develop into the corpus luteum. And so you get the secretion of progesterone and a little bit of estrogen during this phase. Inhibin is also released from the corpus luteum, and that keeps FSH levels relatively low. So here we see it. We have this big increase in progesterone, and that is the dominant feature of this phase. We have estradiol levels kind of being maintained at a reasonable level, certainly not as high as it was pre-LH surge. We have our FSH levels kept reasonably low now, and we have our LH kept low as well as our negative feedback resumes. Okay, and finally we enter our late luteal phase. The corpus luteum dies. Okay. And it becomes a corpus albicans and a tritic corpus luteum, a scar on the ovary. We have a fall in estrogen and progesterone, primarily progesterone at the end of this phase, and because of that, the negative feedback on the release of FSH and LH and the release of estrogen, the release of FSH and LH stops, and so we have our FSH and LH coming back up, and our new follicle begins to develop at the beginning of the next follicular phase. Okay. All right, and here it is in all its glory: the estrogen, the progesterone falling, the LH and FSH starting to come up, and the beginning of a new follicular phase here. Okay. Okay. So having gone through the cycle and having correlated it with gametogenesis and follicular genesis, and with the cyclic changes in the hormones, let's talk about the effect of those hormones on the female reproductive tract. So let's start with estrogen. Estrogen plays its primary role in preparing the ovum for fertilization and trying to get fertilization to take place. So it facilitates movement of the ovum down the fallopian tubes by increasing contraction in the oviducts, and it increases cilia formation and activity. Okay, and it maintains the uterus and its blood supply. Okay, and it facilitates movement of sperm up the reproductive tract in the uterus by increasing contractility and and at the same time you get proliferation of the endometrium and increased progesterone receptors in the endometrium. And so what's happening is your endometrium is proliferating, and eventually the progesterone is going to play a role in stabilizing this proliferated endometrium. Okay, and it also relaxes the cervix. I mentioned this earlier, and it makes the cervical secretions more watery, and it's easier for sperm to penetrate. Okay, so we have an increased proliferation of the myometrium, increased contractility, and it makes the cervix easier for the sperm to get through. And finally, we have changes in the vagina as well. We have a tendency to keratinarize, and the vaginal fluids change such that they're better able to support sperm movement up the tract, okay? Let's talk a little bit about the effects of progesterone, okay? And in many ways, the effects of progesterone are the opposite of estrogen. So where estrogen is priming you to get fertilization, progesterone is really there to nurture the oocyte post-fertilization, okay? So we have more mucus secretion, and this actually does facilitate movement of sperm up the fallopian tubes. But at the same time, you have a decrease in contractility under the influence of progesterone. And the reason why you've decreased contractility here and in the uterus is because you don't want to do anything to cause a fertilized ovum to be ejected too quickly out of the uterus. You want to allow implantation to take place and take it easy on it. So we have the effects on the endometrium, increased differentiation and secretion, but mostly what it's doing is it's stabilizing that endometrium and keeping that layer intact. This nice soft endometrial layer, a nice soft pad for this fertilized ovum to land in and implant in, okay? So again, low contractility. We don't want to eject this thing out. We want to let it embed itself into the wall, and we maintain this nice soft endometrial, vascular endometrial pad for it to implant in, okay? And at the same time, we have formation of a cervical plug. So these watery secretions under the influence of estrogen, they become dense and viscous. And you have a more active musculature. You crank down on the cervix. And so what you're doing is you're retaining the contents of your uterus and taking it easy in the environment, making the environment around that ovum easy, making it easy for it to implant and embed itself and develop, okay? And then finally, we have increased differentiation, decreased proliferation of the vagina here, okay? So here is a diagram that does a good job of emphasizing what's happening here. During the follicular phase, under the influence of estrogen, we're developing our endometrial layer. It's becoming more vascular, and you can see it's increasing here quite a bit. It's becoming proliferative, okay? And this is here's our developing follicle, okay? And that's under the influence of estrogen. Then progesterone goes up in the luteal phase. That stabilizes this layer, keeps it intact, keeps it in a form where this released ovum can find its way down and embed itself in it and develop into an embryo, okay? And then finally, after the luteal phase, our progesterone drops along with our estrogen, and this endometrial layer slows off, and what you get is menses and bleeding, okay? Because that is this endometrial layer slowing off of the uterus and coming out through the vagina, okay? So let's talk a little bit of what happens when that progesterone level drops. The estrogen and progesterone drop. This is the end of our luteal phase. That stimulates lysosomal enzymes within the endometrial layer itself. They activate phospholipase and cause phospholipid to be converted to arachidonic acid. These are all second messengers that are involved in this slowing of this endometrial layer. The arachidonic acid stimulates prostaglandins, and in this case, as opposed to the prostaglandins that are involved in ovulation, the prostaglandins here cause vasoconstriction, local vasoconstriction, and of course, with no vascular supply, the cells become ischemic and die, and necrosis takes place, and the endometrial layer slows off, and bleeding takes place. And this is how the menstrual, this is how menses develops with the fall in progesterone and estrogen at the end of the luteal phase. And you should remember this pathway. It's reasonably important, okay? And finally, let's end up with covering, once again, a little bit more about the effects of estrogen. We talked about the effects of estrogen on the female reproductive tract. We'll wrap up by just simply looking at this box with some of the general effects of estrogen in it. Please do not memorize this table. Just be generally aware of the effects of estrogen really all over the body. They will become most important to you when we talk about menopause. And again, we'll concentrate on menopause as a clinical syndrome and the life cycle block, but obviously menopause takes place in the absence of estrogen. So when estrogen goes down, these effects of estrogen disappear, and that can cause changes normal changes in the health of the typical female postmenopausal. So remember in particular that estrogen has effects on bone. And generally speaking, what it does is it inhibits bone resorption, okay? And so when estrogen is absent, post-menopause, you get more bone resorption, your bones become thin, and this is known as osteoporosis. As many of you know, this is something that's very common in older postmenopausal females. This is the reason why, and you should remember that, okay? Estrogen triggers the growth spurt in the long bones that you see in females during puberty, and then you get fusion of the epiphyseal plates and cessation of growth, and it plays a role in that as well, all that associated with the increase in estrogen that you see post-menopause. And it has effects on the kidney in terms of producing more active vitamin D, which increases calcium absorption from the GI tract. This, of course, has implications on the postmenopausal female as well. Don't worry so much about these, but we talked a little bit in an earlier lesson about the effects of estrogen on the cardiovascular system. These are mostly positive. And these effects on the liver also are positive effects on the cardiovascular system. You increase HDL and VLDL, and you lower cholesterol and LDL. So when estrogen goes down, these positive effects, or these effects on the cardiovascular system disappear. It also has an effect on electrolyte balance, stimulates formation of angiotensinogen and aldosterone, and it enhances sodium reabsorption from the kidney, and it has an effect on thyroid function as well in terms of increasing TSH secretion. And that'll be emphasized in another lesson, this thyroid function. Okay, so again, don't memorize this, but do be aware of these effects, and in particular, maybe pay some attention to the effects on bone, and be aware of those in particular for our lesson, okay, and for the exam, at least in terms of the physiology. All right, that's all I got. Thank you for your attention, and I'll see you guys in the rooms.